The Ultimate Frozen Shoulder Therapy Guide, Brian Schiff. Introduction. Adhesive capsulitis, a condition commonly referred to as a frozen shoulder, can be a devastating condition for people. While it affects many people differently, it always causes significant shoulder pain and stiffness. This in turn directly limits the ability to perform activities of daily living and recreational activities. Many people suffering from shoulder pain and dysfunction have limited or restricted movement of their shoulder. Limited range of motion is also common for those experiencing pain related to rotator cuff injuries, arthritis, impingement, and shoulder bursitis. It is important to fully understand the relationship between the decreased motion and pain in the shoulder. Many make the assumption that decreased movement is the result of stiffness, and actually, it is often affected by pain and inflammation. Simply put, pain prevents many shoulder pain sufferers from moving their arm through a full arc of motion or in certain ways. With that said, stiffness definitely limits motion, but in many cases, pain leads to avoidance of specific movements, which in turn can actually increase the amount of stiffness. Below, I will review normal shoulder motion values to give you a better idea of how a normal shoulder moves. Movement pattern, normal motion, and functional motion. Flexion, 180-degree, normal motion, functional motion, 120 to 150-degree. Abduction, 180-degree, 120 to 150-degree. External rotation, 90-degree, 65 to 90-degree. Horizontal external rotation, 90-degree or more, 65 to 90-degree. Horizontal internal rotation, 75-degree, 60 to 75-degree. Reach behind back, bottom of shoulder blade, top of hip. Abduction, elevation away from the side of the body up toward the ear. Horizontal external rotation, motion is similar to that of cocking to throw a ball. Horizontal internal rotation, opposite downward rotation of external rotation. If you found the previous section a bit confusing, not to worry. I simply wanted to give you an idea of what a normal amount of shoulder motion really is. The reality is that the majority of healthy people do not have full range of motion. However, to perform most activities of daily living, it is only necessary to have the functional range of motion listed. This is important as I do not want people to expect full motion or push too hard in an attempt to achieve it. In the following section, I will outline different types of shoulder pathology and how it affects your shoulder motion. It is possible to suffer from more than one condition at the same time, example arthritis and rotator cuff tendonitis. It is necessary to understand how these different conditions present as they may imitate one another or even occur simultaneously. Sometimes frozen shoulder is a primary condition while at other times it is secondary to another condition. Osteoarthritis. Unfortunately, the aging process takes a toll on most of us over time. Normal wear and tear occurs with daily life, but it may be accelerated based on participation in overhead sports, manual labor, and repetitive use. Eventually, most of us will become affected by arthritis if we live long enough. It usually affects adults as they enter their fifth and sixth decades of life, but may also occur earlier based on trauma or higher intensity activity levels. It is possible to suffer arthritis in the shoulder itself, glenohumeral joint, which means the actual cartilage of the on the end of the arm bone degenerates and the space between the head of the humerus, upper arm bone, and the shoulder blade becomes smaller. This leads to increased friction and compression. In turn, the typical symptoms include grating, grinding, pain, and stiffness. The affected shoulder is often stiff in the morning and sore as the day goes along. Another source of limited motion is arthritis at the acromioclavicular joint, place where the clavicle meets the top of the shoulder blade. This site is a common spot for bone spur development and potential rotator cuff damage related to the spur. The spur bites down into the soft tissues and eventually creates a small tear or hole in the rotator cuff. It is often painful with reaching overhead, across the body, or behind the back. Therefore, these motions may be limited. Overhead lifting may also increase pain in this joint. There is no cure for arthritis. Stretching and exercise are helpful in reducing pain and improving or maintaining range of motion. Much like exercise, I do not advise pushing through painful range of motion. However, if the only problem is arthritis, no soft tissue damage or tear, it is acceptable to stretch to the point of mild discomfort, provided the discomfort does not increase with repeated stretches or linger for any significant period of time following the stretching or range of motion exercise. Moderation is the real key to managing osteoarthritis. On a scale of 1 to 10, with 10 being worst possible pain imaginable, I do not advise enduring any discomfort with stretching that exceeds 2 to 3 by 10. Pain is subjective, so ultimately you are in charge of monitoring and adjusting the stretching program based on your own body. Rotator cuff tendinitis, tears, impingement on bursitis or bursitis. Damage to the rotator cuff is entirely different condition compared to arthritis or pure shoulder stiffness. In this scenario, the motion is primarily limited by pain. This is not to say that you will not have some muscular and or joint tightness, but the real cause for the restricted movement is pain and simple shoulder pain. Without eliminating or significantly reducing the shoulder inflammation, you will not eliminate the pain and regain full use of the shoulder again. What does this mean to you? First, you must recognize that forcing the arm to move through a painful arc of motion will not help resolve the problem. With rotator cuff problems, once the inflammation subsides, the motion automatically improves. The reason for this is that the motion is only inhibited by pain and not truly limited by tightness. Therefore, it is best to limit stretching or range of motion within the comfortable to slightly uncomfortable zone. You will be able to gauge the status of the pain and inflammation merely by available pain-free motion in the shoulder itself. With tendinitis, the most restricted motion with regard to pain is typically between 70 and 120 degrees of elevation, extreme overhead positions, and reaching behind the back. However, this is not always universally true for all people. If you have a tear, you may see similar restrictions, but at a time with a complete tear, there be little or no pain with motion, just plain weakness. In this case, it is best to attempt to move the arm through as much as range as possible to avoid contractures, shortening of the soft tissue, and joint stiffness. Impingement is really not much different. With this situation, the person typically has pain related to compression of the rotator cuff or bursa related to arthritis, calcification, or bone spurs. This inflammation may be transient and occur during times of extra stress or increased load on the shoulder. It is best to once again be cognizant of the pain and not force the shoulder through a painful or limited range of motion. Bursitis, often confused with tendinitis, is treated in the same way as the rotator cuff tendinitis. Again, move the shoulder as tolerated based on your pain. As the bursitis resolves, your shoulder will move easier and further without pain. Gradually increase the stretching and range of motion based on pain. Forcing beyond the comfortable level only serves to increase the inflammation and perpetuate the pain and limited motion. Frozen shoulder. This is a diagnosis that is easily made based on the limited motion of the shoulder itself. It is more common in women, and most people affected by this condition will exhibit a capsular pattern. This condition is also more frequently seen in people suffering from diabetes. Overall, it affects approximately 2 to 3% of the population. This simply explains the motion that are limited in an increasing order as follows: external rotation, abduction, internal rotation. While not a hard, fast rule, this pattern of tightness is generally true. What is a frozen shoulder? Within the shoulder joint, you have a soft sac or expansion known as the capsule. These folds of tissue serve to stabilize the shoulder and exist in three distinct portions: anterior, posterior, and inferior. The medical terminology given to this condition is adhesive capsulitis. In plain terms, this means that portions of the capsule become inflamed and consequently shortened. This leads to the shoulder tightness, exquisite pain, and significantly limited range of motion. Causes of frozen shoulder: insidious. This means the condition occurs for no apparent reason at all. You may simply wake up with the pain and limited motion. I have seen this many times in my clinical experience, and it is hard to understand why it comes on. You will see markedly limited motion within few weeks. There is some evidence to indicate a genetic link to this condition as well. Trauma. In this scenario, a person often experiences significant trauma related to a fall, motor vehicle accident, or other blunt trauma to the shoulder. I once worked with a patient who was knocked down by a wall of water in the ocean and subsequently developed adhesive capsulitis. Diabetes. Research has shown that people with diabetes are 2 to 5 times as likely to develop this condition and more likely to have it in both shoulders. The condition is often more severe in these situations as well. Inflammation coupled with immobilization. This case may involve someone who suffers an injury or is recovering from a surgery and is placed in a sling. Subsequently, the individual avoids moving the affected arm because of pain and spasm. Over time, the capsule becomes shortened and tightens up. I have seen this with patients following shoulder dislocations, humerus fractures, severe tendinitis, and rotator cuff surgery. However, immobilization alone does not cause this condition. Autoimmune reaction. In some cases, it appears tendon degeneration may trigger a response by your own body in which the capsular tissue becomes thickened and fibrotic, hardened. Some feel this explains why most people affected are older, between ages of 40 and 60. Frozen shoulder is more prevalent in women than in men and typically affects the non dominant arm. It may take anywhere from 6 to 2 to 3 years to completely resolve, but it will eventually go away on its own. Physical therapy is often prescribed and may have limited results based on the individual. There are three phases of frozen shoulder: freezing 1 to 6 months, frozen 6 to 18 months, and thawing 12 to 36 months. These are general time frames and may not be exact in every case. Diagnosis: many shoulder problems present with similar signs and symptoms, so it is important to have a thorough medical evaluation done. The shoulder joint is limited with both active and passive motion. The end feel of the movements is also typically firm. However, pain with movement often prevents you from taking the joint to the point of stiffness, tight range in this first place. So the actual end field may be empty. X-ray findings may be normal or provide signs of arthritis, osteoporotic changes, decreased subacromial space, calcium deposits, or other degenerative findings. Common signs and symptoms: intense pain in the deltoid region. Pain may radiate down the arm. Pain is worse with shoulder motion, especially external rotation. Pain is better with rest. Pain is worse at night and often disturbs sleep. May have associated pain in the upper back and neck. Guarded shoulder movements. Difficulty reaching behind the back. Reduced arm swing and walking. Those affected typically hold the arm close against the body. Rounded shoulders and stooped posture. Muscle spasms. Trigger points in the upper trap muscle. Treatment: the treatment for a frozen shoulder typically involves moist heat prior to joint mobilization, stretching, selected range of motion exercises, low level strengthening and ice following activity or exercise. Non-steroidal anti-inflammatory meds are also prescribed to ease pain and inflammation. Note: it is critical to move and use the arm as much as you can in a tolerable range of motion. Favoring the arm or discontinuing use will only make it worse. If conservative measures fail to improve the pain and use of the arm, your physician may inject the shoulder with cortisone. Injection alone do not resolve the situation, and they are best used in conjunction with an exercise program. They are largely used to decrease pain enough to allow the person to benefit from exercise and stretching. Beyond this, the next step is manipulation under anesthesia, in which the physician manipulates the arm to break up the adhesions. You are not awake for this. This usually frees some motion immediately, but in my experience, typically creates additional inflammation and yields modest gains in most cases. This is used in prolonged cases without much improvement. It also necessitates daily therapy for at least 1 to 2 weeks to help ensure the adhesions don't form again. The final option is usually surgery to cut the adhesions loose. I have not seen this often, but some surgeons will use this if the person is extremely affected and no other course of treatment has helped. I have again seen only mixed results with this procedure. Ultimately, I recommend minimizing abuse activities, those that cause pain, and following a day stretching and range of motion program based on the restricted movements in the shoulder. Heat and ice are typically helpful. You must remember that this condition takes time to improve. I have seen great results in 3 to 4 weeks and also known patients who did not get much better for a period of 12 to 18 months. Regardless, maintaining your available motion and trying to gradually restore full motion is a daily requirement to overcome this frustrating condition. In the coming sections, I will discuss the differences between static stretching and range of motion exercises. More importantly, I will help you determine which exercises are best for your condition so you can improve motion without increasing your arm. This is a key point in determining how fast you will recover. Stretching versus range of motion exercises. Many people become confused about what they should actually do to improve shoulder motion and reduce stiffness. Hopefully, I clearly made the distinction between pain inhibited range of motion and true stiffness in the previous section about shoulder pathology. Based on your condition, you may only need to do stretching or range of motion exercises. In most cases, you will require both types of exercises to solve your problem. Stretching, for the purposes of this guide, stretching will really equate to static stretching. This means taking the point to a certain point in the range of motion and holding the position for a specified amount of time. It does not mean bouncing up and down, rocking forth and back, or holding the stretch for any less than 5 to 10 seconds. Passive stretching is very effective in improving range of motion when done properly. Did you get that? It must be done the right way, time and time again. Being too aggressive or failing to hold a steady stretch will not yield favorable results and often cause more pain. Below I will outline the key aspects of effective static stretching. Gradually ease to the stretch, never move rapidly. Go to a point of mild to moderate stretch and slight discomfort. Hold the stretch between 5 to 30 seconds. During the stretch, attempt to stretch further if tolerated. Maintain upper alignment at all times. Slowly return to start position after completion and repeat. Now when it comes to stretching, I will not pull any punches. To be successful, you need to do it every day. Soft tissue has memory and it only lasts for 24 hours. So stretching every day, other day will really do you no good if you have stiffness. With that said, I will now address the frequency and duration of stretching. Research has been clear that holding a stretch for 20 to 30 seconds seems to be most effective. Any more is not necessarily better, but any less is not as productive. However, in some, stretching is better than none. So if you can only hold the stretch for 5 to 10 seconds to start, that is okay. Gradually work to increase your time and simply do more repetitions of the same stretch. In the terms of how many stretches you do, I typically advocate doing each particular stretch 2 to 3 times and repeat the routine twice per day. While this is not an absolute rule, I have found it yields the best results. In some cases, you may start with 2 stretches with 20 seconds once per day and eventually work up to 3 stretches 30 seconds twice per day. Do not get hung up on the exact numbers, but rather focus on strict form, daily execution of the stretches, and being respectful of your shoulder pain and allowable motion at the time. Range of motion. Range of motion exercises are completely different from stretching. By my definition, these exercises simply involve moving the shoulder through the available range of motion at a specified pace and repeating the action for a set number of times. These exercises are extremely effective for treating all the aforementioned problems. The most important thing to remember with these exercises is to remain respectful of the tolerable motion you have based on the pain. In other words, you should not force the range of motion of the expense at the expense of significantly increasing the pain in the shoulder. However, in more advanced cases of frozen shoulder, it may be necessary to be more aggressive with stretching based on the motion loss. Over time, the range should naturally improve as the pain and stiffness resolve simultaneously. This does require patience on your part, but I can assure you will pay big dividends in the end. Most people will have limited motion in certain directions and require very specific range of motion. This is often the case with rotator cuff tendonitis, tears, and bursitis. With arthritis and shoulder, most people will need to do a full spectrum of exercise to make sure they are actually moving all parts of the shoulder. Now I will further define range of motion and stretching into three distinct categories or movement. These categories will help you guide you in choosing how to administer your own exercise. It is a logical progression based on the severity of your pain and limitations with regard to strength deficits and your present functional level. Categories of stretching and range of motion exercise. Passive. This means you use the unaffected arm to move the affected or injured shoulder through the range of motion. The injured shoulder does absolutely no work. This is often best for extremely painful shoulders that have little to no movement or very limited strength. Active assisted. In this approach, you follow the injured shoulder to do some of the work or movement on its own, but you predominantly utilize the unaffected shoulder or arm to guide the movement and perform the majority of the work. This is often chosen in cases where there is some documented stiffness coupled with weakness. Assisting will help reduce inflammation, especially with exercise that are performed against gravity. Active. Now you let the affected shoulder do all the work throughout the entire movement. This is effective for shoulder with a mild case of frozen shoulder that is mildly painful but not significantly weak. It can also be used in cases of tendonitis and arthritis. Moving to his this level of exercise is the goal for everyone, but it should only be done when the pain is decreasing and not inhibiting the motion on a large scale. This particular method is also effective for strengthening the shoulder affected by a partial or complete rotator cuff. While there is no exact science to selecting the appropriate method for your shoulder, I always advise to err on the side of caution. Shoulders are very susceptible to increased inflammation through over-aggressive stretching and range of motion. Therefore, if you have any doubts, begin with passive exercise and gradually advance to the active exercise. Typically, I recommend performing a style of set of 10 to 20 repetitions for any particular range of motion exercise. This should be done 1 to 2 times per day based on your pain. Pain tolerance and degree of limited motion. Is more okay? Yes, provided it does not cause pain and actually lead to more restriction in your shoulder motion. Note: performing stretching and range of motion exercises against gravity is significantly harder on the shoulder than doing it with the assistance of gravity. For example, standing and raising the arm overhead is much more challenging than raising the arm overhead while lying on your back. Keep this in mind as you exercise, as it can play a big role in managing your pain and recovery. You may also want to consider using heat prior to stretching for 15 minutes and following up the exercise session with ice to reduce inflammation caused by stretching the restricted tissue.